All righty. So I'm going to be talking about the lateral intrabody fusion, which is a technique of fusion utilizing a approach through the flank. And let me preface this by saying that the patients that we do fusions on are a really small percentage of the patients that we do that come into my office. So the vast majority of patients that I treat are treated non-surgically with physical therapy, anti-inflammatories, injections, and the small percentage of patients that require fusion, the lateral fusion is one of the techniques that we often use. There are some major categories of why we do a fusion, and that includes instability, such as might occur with trauma or fracture, spondylolisthesis, which is a slippage of one vertebra on another, scoliosis, which is an abnormal curvature of the spine, and degenerative disc disease. So let me briefly discuss what happens when discs degenerate, because degenerative disc disease underlies a lot of these conditions. When we're born, we have these nice normal discs, normal height, and as the body ages, some tears begin to appear in the outer portion of the disc. The body tries to heal those by forming scar tissue, which unfortunately does not have normal resilience of normal tissue. And that in turn leads to degeneration of the interior portion of the disc. And then the disc begins to dehydrate, it gets more narrow, the disc tends to collapse. And that in turn places pressure on the small joints in the back of the spine called the facet joints, and they then can become arthritic and develop bone spurs, as you see here. Here's some specimens. On the left, you see a normal spine with normal tall discs. In the middle, you see some early degeneration where the discs have undergone this wear and tear process. They begin to dry out and get more narrow. And then with advanced degenerative disc disease, the spine assumes a bone-on-bone sort of configuration. There are bone spurs that form. The small ligaments in the back of the spine can thicken, and all that combines to crowd some of the nerves that pass through that area. One of the other things that sometimes happens as the discs degenerate is one vertebra will slip forward compared to the other, a condition that's known as spondylolisthesis. Now, when we do fusion surgery for any of these conditions, we have learned that by inserting something into the disc space, the success rate for the fusion is much higher. There are several approaches for performing the fusion. It can be done from the anterior approach through the belly. It can be done from the side, which is what I'm talking about this evening, which is the X-Lif or D-Lif, which is also known as the direct lateral approach. The Tlif procedure with Dr. Falacasa we'll be talking about, or the posterior fusion. So with the X-Lif or lateral interbody fusion technique, there are several advantages, one of which is that it does not require retraction on the muscles in the back. And so the healing is a little quicker. It avoids the risk of an anterior approach, which there are some large blood vessels in the anterior portion of the spine. And so we avoid that by going from the side. It still allows the surgeon to perform a very thorough discectomy and to remove the entire disc. And if you can remove a lot of disc, that means you can put a lot more bone into the disc space and get a higher success rate. And it also allows distraction of the disc space, which in turn creates greater room for those nerves. The disadvantages are that you don't actually get to see the nerves themselves when you do the X-Lif. And so you can't directly decompress them. And also the L5S1 disc is difficult to approach from a lateral approach. One of the main advantages is the fact that we can restore normal disc height by inserting this spacer into the disc space. So here's a little video that gives an overview of what's involved in doing the X-Lif procedure. The patient starts on his side, and we make a small incision overlying whichever disc we're going to be operating on. We use fluoroscopy in order to image the spine so we know exactly where we're working. And then there are these dilators that emit a electrical signal. And there are monitors on the legs. And so if the probe gets close to a nerve, it sends off a signal that's picked up in the legs, and that allows the surgeon to find a safe trajectory that avoids those nerves. And a retractor is inserted, and through that retractor, we get a very nice view of the disc. And through that view, we're able to do a very thorough discectomy and remove most of the disc that's present there. And once that has been accomplished, some type of a spacer is inserted into the disc space. So a spine that is narrowed where the disc space has collapsed, as you see on the left, where it's putting pressure on the nerve. By inserting that spacer, it creates more room for the nerve. And by inserting that spacer, we get a higher success rate. The implant itself is not inherently stable in and of itself. And so some type of supplemental fixation is generally required. Here you see a lateral plate and screws that is used in this case. Sometimes we'll insert screws from the back or a small plate as well. Dressing is placed on the spine, and that's pretty much how the procedure is performed. The key to safely performing this procedure is this intraoperative nerve testing by inserting these electrically stimulated probes, which tell you where the nerves are. And when you get too close to the nerve, the monitor sends off a signal that lets you know that you're too close, and you can alter your trajectory. One of the really nice advantages of this particular procedure is the way that it elevates the disc height. So as the interbody cage is inserted, you can see how that it helps to straighten out the spine. The other nice things about this particular procedure is that there's a large graft window, meaning that there's a big space where we can insert bone graft, and that will then increase the likelihood of a successful fusion. The other thing is that you see here on the right, the implant extends basically from one side of the bone all the way to the other, and by having a large support, there's less likelihood that the implant will displace or subside into the bone, and that also increases the success rate. New implants have been designed that now have these little pores that allow the bone to grow into them. The initial implants were made of a special medical grade plastic called PEEK. Some of the newer implants are manufactured with 3D printing technology, and they're porous, and that allows bone to grow into the implant itself. Here's a couple of examples. On the left, you see a patient with spondylolisthesis and with a very collapsed disc space. And this is his x-rays on the right. You can see how the bone has shifted forward compared to the other one. This slippage occurred due to some fractures in the back part of the spine. That's a type of spondylolisthesis that's called lytic spondylolisthesis. In those cases, we would put a spacer into the disc space and also supplement with some screws. So here you see the before on the left and the after. And so by inserting that spacer, the disc height has been elevated, and then the surgeon has inserted some screws in the back to stabilize it further. Here's an example of a patient that had not a spondylolisthesis, but a disc collapse where the disc had narrowed more on one side than the other, and that led to a curvature of the spine. The spacer was inserted, and instead of using screws, a small clamp was inserted onto the back of the spine. Here you can see from the side view a collapsed disc, and there's that little plate or clamp that's inserted onto the back of the spine. Very nice elevation of that disc space there. Here's a more involved case where there were 3 discs that needed to be fused to correct a curvature of the spine, scoliosis. You can also see how the vertebrae were malaligned side to side as well. The nice thing about the XLIF procedure is that a small incision on the side allows a surgeon to approach all 3 discs through that one incision. And here you can see on the right side how the discs have been elevated, the curvature has been corrected, and it's been stabilized with some screws. Finally, here's a case with multiple discs that were fused. In this case, 5 discs underwent the Tlif procedure. And so because it was such an extensive procedure, it's done in 2 stages. First, the 5 spacers are inserted, and then on another stage, the screws are inserted. And this went from all the way from the thoracic spine down into the pelvis. So just to summarize what I've talked about, the Tlif is a technique for performing fusions that treats spinal curvatures, scoliosis, slippage of the spine, which is spondylolisthesis, and degenerative disc disease. It's safe because of the nerve monitoring that's used, and it has a high success rate because of the large graft window, the large surface area, and the porous implants that are now being used. And some of the key advantages are it allows restoration of the disc height, it allows for indirect decompression of the disc, and it allows for compression of the malalignment. If you have any questions, go ahead and insert those in your in the chat box. And I'm going to now turn over to Dr. Jonathan Falacasa. Dr. Falacasa has been with SCOE since 2016. He sees patients in our Van Nuys office and in Porter Ranch and Valencia offices. So Dr. Falacasa, we're looking forward to hearing your talk.
Thanks, Dr. Grossman. Hi, everyone. I'm Dr. Jonathan Falacasa. I'm one of the spine surgeons at the Southern California Orthopedic Institute. Just to reiterate, I see patients at our Van Nuys, Valencia, and Porter Ranch office. And I'm excited to discuss some other minimally invasive spine surgery techniques with you guys today. I'm going to talk to you guys today about the Tlif procedure. So have my screen up. So let's talk about this. So the Tlif procedure is a fancy procedure which is really called the transforaminal lumbar interbody fusion, which we'll discuss in a minute. And in general, this is a very good technique that could also help, treat very similar conditions that Dr. Grossman just discussed earlier. It's just a different way of doing it. We'll talk about, the advantages and disadvantages of this minimally invasive technique. So just a very brief overview regarding understanding back and leg pain. Chronic low back pain affects 1 out of every 10 Americans, which is why me and Dr. Grossman and a lot of us have a job. It's very, very common. Men and women who suffer from this condition often feel helpless, isolated, and can actually, these symptoms could really aggravate a lot of their symptoms. According to the Bureau of Labor Statistics, back pain was actually responsible for around 60% of cases why people missed work last year. A lot of times when patients come to our office, we don't only ask about back pain. Back pain is one important factor that goes into the evaluation, but another very big factor that we look into is actually leg pain, because during this degenerative process, which Dr. Grossman discussed, as a result of the arthritis, and the changes we see in the disc, this could often result in pinching and pressure on the nerves in the lumbar spine, which often causes a lot of leg pain, which is often kind of referred to as sciatica pain. As doctors, we often kind of discuss that type of leg pain as something called radiculopathy. And when patients have pressure on these nerves, it could often cause such symptoms such as numbness, tingling, pain going all the way down their leg, prickly feelings, and sometimes really significant difficulty walking and associated weakness. That's why often when we are asked to evaluate patients for back pain, we really stress the importance of evaluating if this back pain is associated with leg pain or not, because when someone has a lot of back pain and these discs are degenerated, causing bone spurs or disc bulges, and if there's pressure on a specific nerve, it'll also cause a lot of sciatica pain or radiculopathy. So as Dr. Grossman kind of reviewed earlier, there's many causes of, back pain and leg pain as a result of, the spine. A lot of it is due to natural aging. Some of it could be due to trauma. And kind of in this slide, you could see that, as this person, or in this model, as the spine has degenerated, you could see, the disc is bulging in this case, and you could see this hole where the nerve exits is now no longer open, it's narrow, causing kind of pinching and irritation of the nerve root, which ultimately causes not only back pain, but a lot of sciatica pain as well. Dr. kind of Grossman previously kind of talked about the issues with loss of disc height, which results in this hole being narrowed. This hole is called the foramen, that's called foraminal stenosis. He also discussed, when this process occurs, sometimes this vertebrae could slip forward a little bit, and that's called a listhesis or spondylolisthesis. Other things we look at when we're looking at overall back pain is on the x-rays, we look at the curvature of the back. We look for such things such as not only listhesis or slippage of a vertebrae, but also if the spine is curved, which means often people discuss that as a scoliosis, curvature in the spine in the coronal or frontal plane. And we also look at the side plane of the back too to make sure that curvature looks okay. The curvature on the side view is called the lordosis of the back. As Dr. Grossman discussed, spine surgery and fusion surgeries are often, the last resort. Most of the patients we treat for back and leg pain is initially conservative. So, non-surgical treatment is actually the mainstay of treatment for back pain. And this includes such things as physical therapy, strengthening exercises, in certain situations, rest and activity restriction, injections, anti-inflammatory medications, application of heat or ice. But there's a lot of times where the pathology and what's going on does not, respond to an extensive course of conservative care. And in certain cases, patients are excellent candidates for spine surgery and even fusion surgery where the success rates are extremely successful. So traditionally, not every single patient who requires surgery is going to require a fusion procedure. But, in the past, in order to do a fusion procedure, as we kind of discussed earlier, it requires, getting access to the disc in order to remove it and place a spacer in there that could help restore the normal anatomy and height of the disc. It also often requires, placing hardware in order to help stabilize that segment in order to, restrict abnormal motion and, facilitate those bones fusing. And in the past, a lot of the techniques that were used were very, very painful because in order to access the disc, it required stripping a lot of muscles in your back. It also required, extensive dissection, which often led to a lot of bleeding, long operative times, which ultimately resulted in longer recovery. Traditionally, when we do these fusion procedures, like Dr. Grossman kind of discussed earlier, there's different ways of accessing the disc. You could access the disc through the side, as Dr. Grossman discussed. You could access the disc through the front, which is called an A-lift procedure. You can see that in the first slide. And you could access the disc through the back. So my discussion is going to be a new technique or a newer technique where we were able to access the disc through the back via a procedure where we could do a smaller incision and avoid more extensive dissection and help decrease, blood loss, decrease operative time, decrease soft tissue dissection, which ultimately results in, faster recovery. So A traditional Tlif approach, which means the transforaminal lumbar interbody fusion where you go in the back, requires in the past where physicians would have to make really large incisions on the back, and they'd really have to strip all the muscles outward to allow for sufficient access to the spine, and allow efficient access in order to place these spacers that we talked about earlier in order to restore the normal height of the disc, as well as in order to enable an area for fusion to occur. So we'll talk about this, but the benefit of the more modern, minimally invasive surgery techniques is it allows surgeons to achieve the same goals that you see with these classic large open surgeries while minimizing the collateral damage associated with the open approaches. Surgeons are able to avoid long and extensive muscle dissection, which ultimately results in reducing tissue injuries, decreasing blood loss, reducing postoperative time, shortening hospital stay, and helping expedite recovery for patients to get back to their better, quicker quality of life. So with the minimally invasive XLIF procedure, I call it the maximum access surgery transforaminal lumbar interbody fusion. This approach minimizes the amount of muscle disruption by approaching the spine at a different angle. It starts at an angle, and you use kind of more of a blunt splitting dissection rather than a stripping and disruption of the muscle tissues in order to get to where we need to be. And with these newer retractors that we have, we're able to gain access to the disc, as well as, even though we're using smaller incisions, with these different devices, we're able to see what we need to see very efficiently, and access the disc very efficiently, and put in our hardware without making large incisions. And this is a picture of the device where we go off from the center a little bit, and we do more of a muscle splitting approach rather than a cutting approach. And this is kind of the distractor we use to kind of get to where we need to be as minimally invasive as possible. So once again, just kind of reiterating the points, compared to the traditional Tlif approach, by doing the mass Tlif approach, we're able to reduce blood loss, make a smaller incision, disrupt less muscle, shorten hospital stay, and have patients return to work quicker. This procedure is often indicated and is a good procedure for patients who have significant disc degeneration with significant back pain, who have failed an extensive course of conservative care and require a fusion procedure. It's helpful in patients who have a slippage of a vertebrae, which we'll talk about in a minute, called a spondylolisthesis. And, as well as patients who have, instability, scoliosis, narrowing of the canal where the nerves are, who require a fusion procedure. So you can see in this kind of picture, you kind of see a healthy spine on the left where there's nice amount of space for the nerves and the nerves aren't being pinched. And you can see on the right, a picture of a diseased spine where the nerves are being pinched, the discs are bulging, and this patient likely has not only back pain, but because the nerve is being pinched, they often have sciatica or radicular pain as well, which we refer to as leg pain. So a case presentation, this is a patient that I had where I used this approach. I've had many patients that have really benefited from this, and this is just one of the presentations I wanted to pick. It was a 64-year-old female. She had a chronic, long-standing history of not only back pain, but bilateral buttock, thigh, and leg pain. Her pain kind of radiated to her buttock, thighs, and shins. She complained of numbness and tingling on both the top and the bottom of her foot. She had pain that was worse with ambulation and better with rest. Often when these nerves are being pinched in the canal, patients often have worsening symptoms as they get up and start walking. And as they rest, these symptoms can improve. That's a term we use to describe that is called neurogenic claudication, which is often seen in patients that have this condition where the spine is narrowed called spinal stenosis. So you could see the x-rays of this patient, on the side view, you could see this bone right here. This is called the L4 bone, and this one right below it is called the L5 bone. And you could see this bone has kind of slipped forward relative to the L5 bone. This condition is called a spondylolisthesis. The reason that we discuss doing a fusion in these cases is often if you just have the spine narrow here, if you don't have a slip and you don't have instability, you could just go in there and only do what's called a laminectomy procedure, which is basically a procedure where we just open things up to make space for the nerve. The problem is when you have a vertebrae that slipped a little bit and there's instability, if you do the laminectomy procedure, which is a name for the procedure where we just open up for space for the nerve, you create more instability. So that is why Dr. Grossman and myself have been showing these examples where there's a slippage as a good indication for a fusion procedure. So you can see this is another imaging study. The prior images was an X-ray. This right here is an MRI. An MRI is a better study to show not only the soft tissue and the discs better, but it also shows the nerves better. You can see this is a side view of the spine on an MRI, and you could kind of see these are the nerves right here going down, and you could see things are going okay until you reach this area, which is the L4, L5, one of the most common areas to see the slippage. And you can see this L4 bone has slipped forward relative to this L5 bone, and you could see as a result, and the changes that have occurred, the nerves in this area are being compressed, which is causing not only the back pain, but the buttock, thigh, leg pain, tingling, and numbness. This is another view of what we're seeing here. This is a cross section. It's called an axial cut. What you see here is just a different view of what's going on at the L4, L5. In this situation, this is the patient's tummy, this is their back, and this is the disc, and this is actually, this area is the space where the nerves exit. And you could see that there's a lot of pinching of the nerves in this area. There's really not much space for the nerves to get down to the legs, which is why this patient has a lot of numbness, tingling, and leg pain. Another thing you could see is on this view on the side, you could see this L4 bone once again going forward. So, if we did this surgery where we just opened space for the nerves, which is called a laminectomy or decompression, without doing a fusion where we put screws and rods to hold this in place, there would be what's called increased instability where this bone could kind of slide more forward. So this is one of the reasons why this patient would be a great candidate for a fusion procedure. So you could see in this picture right here, we did this Tlif procedure where we did the laminectomy, which means I can remove the bone and made space for the nerves. And we were able to place this spacer, this interbody spacer called a Tlif spacer. And we were able to kind of bring this bone back to where it belongs and what we call reduce the slippage and kind of hold everything in place with the screws and rod as well. Thank you very much. So without further ado, the next person I'm gonna introduce for our lecture would be Dr. Nicholas Jain. Dr. Nicholas Jain, I believe, joined us at SCOE about 2 years ago. He's an orthopedic spine surgeon who's excellent, and he practices in our Bakersfield office.
Okay, thank you very much, Dr. Falacasa. If you could stop your screen sharing, then I can go ahead and start with mine here. All right. Okay, thank you very much, everybody. Hopefully you can see my screen now. My name is Nick Jain, and I'm going to be talking about a different procedure for a common problem that Dr. Grossman and Dr. Falacasa have gone through multiple alternative procedures for, which are great procedures and very well tolerated. So just a little bit about who I am. I'm a fellowship trained orthopedic spine surgeon, just like Dr. Grossman and Dr. Falacasa and Dr. Schoppler. I'm a California native and have never left, thankfully, and don't ever plan to. I was born in Orange County. I did my undergrad up at Stanford and then returned home for 10 years to do medical school and residency in orthopedic surgery before going to USC, where I completed a combined orthopedic and neurosurgical fellowship in spine surgery. And, you know, I, like many of you, probably enjoy an active lifestyle, trying to get outside. I'd like to play golf, travel, and snowboard. But just talking about low back pain, which is, you know, one of the most common things we deal with as human beings in America, you know, 50 to 80% of Americans will have low back pain at some point in their life. And it's the second most common reason people go to the doctor in this country. The good news is the vast majority of time, 90%, it gets better within 1 year. But there's so many different causes of back pain, and they're not all the same. So just like Dr. Falacasa and Dr. Grossman alluded to, there's many different parts of the spine. You have the vertebral bodies, or the bones that are in between. These are these square-shaped bones with the discs or the shock absorbers in between the bones. And in the back, you have these paired facet joints, and they all work together to allow for spinal motion. But as we age, we undergo what's both Dr. Grossman and Falacasa alluded to, the degenerative cascade, where the discs begin to lose height and motion, which changes balance forces in the spine and cause overload of the facet joints, leading to bone spurs. And this can impinge nerves and cause nerve pain radiating down the back or legs, and cause worsening low back pain. And the lumbar spine is the most common site of arthritis of the spine, and it's due to the stresses and strains applied to one's spine over their life. And the disc is usually the first structure that's affected by these stresses and strains. And certainly acute injuries can exacerbate or make things worse for these problems. This is one of my favorite diagrams, and it's from a study that was done about 40 years ago, where scientists measured the amount of pressure that goes across discs in the lumbar spine in different positions. And you can really see that, you know, when you stand up, if that's 100% of disc pressure, when you're laying down, you have about a quarter of that amount of pressure going across the discs at that level. But if you sit, you actually have 40% more pressure across a disc than when you're standing. So, you know, in today's society, especially during this COVID pandemic where people are stuck at home and on their computers, we're all stuck sitting like this with bad posture, leaning forward, and you can have 85% overloading of lumbar discs when compared to a standing position. So really, this is going to become an epidemic in its own right, and already has been. There's so many different causes of low back pain, and every patient is different, and every patient can have a combination of all of these, or some of these, or portions of these multiple diagnoses. And that's where, you know, the skill and art of what we all do as spine surgeons comes into, where we try to look at all of these problems and figure out which one is actually causing a person's pain or symptoms. But today I'm just focusing on one of these conditions, and that's lumbar degenerative disc disease, which Dr. Grossman and Dr. Falacasa have already talked a little bit about. And that's wearing out or thinning of the lumbar disc. Usually this diagnosis is made with physical examination, X-ray imaging, MRIs, specifically looking for degenerated disc with modic end plate changes or changes in the structure of the disc itself. So on this MRI, this is a side view where you see the square-shaped vertebral bodies. You see the nice white plump discs at the levels in the upper lumbar spine. And these two bottom discs here at L4-5 and L5S1, you can see are black, dark, and starting to thin out. You can see a small disc bulge or tear there of the annulus. And you see these changes are signal within the bone called modic end plate changes, which is just edema in the bone because the shock absorbing ability of the disc is disappearing. So the bones begin to bang on each other, and that causes some edema within the bones themselves. CT scans can also be useful. Typically, like both Dr. Grossman and Falacasa alluded to, we always start with kind of non-operative treatments, conservative care, medications, anti-inflammatories, physical therapy, core strengthening, chiropractic treatments, acupuncture, traction is a popular one, and some procedural interventions such as injections into the facet joints, the discs, or what's called the epidural space, which is one of the most commonly performed pain management procedures you've probably heard of. Exercises are a great way to help treat these conditions too. And stem cell injections are also a popular treatment with no scientific evidence or basis for their use. So I'd highly caution you all to before proceeding with those, and to really look into those and have a meaningful discussion with the physician performing them before proceeding. But then we kind of move on to these surgical treatments. And there's multiple surgical treatments in the spine, from lumbar decompressions, minimally invasive laminectomies, microdiscectomies, fusions, and even lumbar disc replacement. And Dr. Grossman and Dr. Falacasa gave a great overview of 2 ways to perform lumbar fusion in kind of a modern and minimally invasive technique, either through the side with the Tlif procedure or through the back with the minimally invasive Tlif procedure, which are great options, certainly. But there's a new treatment that's come out. Just going to fix this here. Called the Intercept procedure. It's a novel procedure that's been done. It's a minimally invasive treatment. There's no fusion involved. There's no implants involved, and it's an outpatient surgery. There's minimal downtime or time off work, and there's excellent scientific data with randomized controlled trials to support its use. So how do you know if Intercept is for you? So it's typically a procedure geared for patients with chronic low back pain due to lumbar degenerative disc disease that's been ongoing for more than 6 months, refractory to conservative treatments. And this is a perfect example of an MRI of a patient whose disc is not all that collapsed, but you can see significant modic end plate changes on the MRI, which indicates that the disc is losing normal function and wearing out. So this is just a brief video of the procedure, of how it's performed. Small trocar is inserted into the bone percutaneously through a stab incision in the low back, and a RF probe is ablated into the bone, targeting this small nerve inside the bone called the vasovertebral nerve. A heat generator causes a painful burning signal, which burns the nerve and takes away its ability to transmit painful signals from the disc to the brain. So it just removes the pain-generating signals through a tiny outpatient surgery. So what's the data on this? Is this a real procedure? Does it have some good evidence to support its use? And it's only been done in the United States for the last 5 years. And it was FDA approved 2 years ago, but the original studies were done 5 years ago. And there's a 60% reduction in pain, objective pain markers at 5-year follow-up after this procedure. And patients had a pain score reduced from an average of around 7 to around 2. And that maintained itself throughout 5 years of follow-up. So there's significant data to show that this procedure is effective out to 5 years. And it's very safe with a very low complication rate of less than 0.5%. And 65% of patients say they've resumed the level of activity they enjoyed prior to any low back pain in these kinds of studies. But one thing I'd caution you to learn about before you go into this is nerve ablation procedures in the lumbar spine have been around for a long time. But this is a very new and different nerve ablation procedure because it's targeting a completely different nerve. Typically, when pain management physicians talk about radiofrequency ablation, nerve burning, anything that people say are RFA, they're referring to facet radiofrequency ablation, which targets the medial branch nerves that innervate the facet joints. And these are great for facet-related pain. And this is just a small video that I'm trying to show you here. That shows it's a little bit different than what you'd see here. Can you guys see the video right now? Well, if not, the vasovertebral nerve ablation, however, is extremely different. This is targeting a different nerve called the vasovertebral nerve, which is within the vertebral body itself. And this is not a facet-related problem, as most people have degenerative disc-related problems. So we're treating a very different problem. And this is intraosseous, not outside the bone. It's within the bone itself. So, I'm a big proponent of this procedure and have been fortunate enough to be one of the early adopters of it and have done more than anyone in Southern California. And this is just a patient review I took from Google of the procedure itself. And I'll give you guys a chance to read it. But really, this procedure is great for people who are interested in getting back to living. And that's kind of the mantra. It's trying to reduce pain, improve function, and eliminates the need for a larger magnitude surgery. Certainly, this is not for every patient, and all those other conditions I listed, they oftentimes necessitate a fusion procedure. Not every patient qualifies for this procedure, and many patients do need a lumbar fusion. So don't get me wrong that this is a cure-all for everybody, but for certain people, this can be a great treatment. So just wanted to say thank you again, and I'm going to pass the baton on to Dr. Shopler, our senior leader here in spine surgery, who's going to talk about kyphoplasty with you now.
There we go. Thanks, Dr. Jane. I'm pleased to give a little talk tonight about kyphoplasty for vertebral compression fractures. You heard Dr. Grossman and Dr. Falacasa talk about fusion techniques, and you heard Dr. Jane talk about the Intercept procedure, which is an alternative to fusion technique. I'm going to talk about something totally different, which is about fractures of the vertebra, vertebral compression fractures, which are an unfortunately common element in our society. And I'll give you a little information about that as we go forward. I'm in the Bakersfield office with Dr. Jane. The other two doctors you heard from are down in the southern reaches of our practice. Up here, we still drill for hydrocarbons. And soon, I think that slide will have to be replaced with a big solar farm that they're building out here. We also are responsible in Bakersfield for every baby carrot you ever saw in the grocery store. So this is what we do here in Bakersfield. I'm going to talk about kyphoplasty. What is a kyphoplasty? Kyphoplasty is a surgical procedure that involves reinforcing the soft fractured vertebral bone, usually with osteoporosis. And it's done by placing a balloon into the bone with X-ray guidance, inflating that balloon, and then withdrawing the balloon and replacing that now cavity in the bone with bone cement, which is polymethyl methacrylate bone cement. It's the same bone cement we've used for decades for total joint procedures. So vertebral compression fractures are very common. The commonest cause is osteoporosis. We'll talk about that just briefly. Other reason people have vertebral compression fractures is, for example, big falls. We typically will see some compression fractures around Christmas time when people are putting up their Christmas lights and fall off the ladder and land on their bottoms and crunch their vertebrae. The picture here demonstrates a compression fracture. Tumors and infection are other causes of compression fractures, but I'm not going to really address those here tonight. The typical symptoms that you see from a compression fracture is pain. It's a painful procedure. That's why people come and see us, because it really hurts. Their backs are irritable. They can't sit upright comfortably. They can't stand comfortably. They can't move around comfortably. Pretty much the only thing they can do is lie down. And even then that hurts when they get in and out of bed. There's usually what we call a kyphotic deformity, where the vertebra is compressed. A kyphotic deformity means it's sort of like a hunchback deformity. Usually it's not a severe one, but you'll see the patient's alignment of their spine is tilted forward in that sort of hunchback alignment. Most of the time there's no leg pain with these fractures, unlike the other types of disorders that you saw earlier today. Most of the fractures are due to osteoporosis. Osteoporosis can be largely prevented with good diet, some activity, some vitamin D, and in many cases, estrogen supplementation in females. But the risk factors for osteoporosis are listed here. I don't need to go through all of them, mostly female. Alcohol and tobacco contribute. Early menopause, such as women who've had early hysterectomies, thyroid disease, and frequently patients who have calcium or vitamin D absorption problems, sometimes due to their GI tract, can all get osteoporosis in their later years. And what osteoporosis is it's thinning out of the spongy bone inside the vertebra in this case. Osteoporosis is a problem that affects all your bones, but in the vertebra, it affects in particular the spongy bone in the center of the vertebra. The normal one is on your left side here, where the cancellous bone have these trabeculae that you see here. The trabeculae in normal bone have good calcium content, and they're dense and supportive of your body mass. When you have osteoporotic bone, you see that these trabeculae are thinned out, they're scarce, they're rarefied, and they lose their calcium content. So the bone is weakened by the loss of these trabeculae, and when the bone is weakened, it's prone to fracture. These are the statistics and epidemiology of osteoporosis. About half the women in America will get some osteoporosis. It's more common in females, postmenopausal females of Northern European extraction, and not as common in men. About 700,000 osteoporotic vertebral compression fractures occur every year. The patient has pain, we take x-rays. X-rays usually identify a compression fracture. Other techniques we will use include a CT scan or an MRI. Here's a picture of an MRI of a patient who has a compression fracture that's hard to see on x-ray, but you can see that the vertebra labeled T8 has that changed signal. You can see the other vertebrae look different, darker gray than the T8 vertebra. And also the T12 vertebra down below is wedged and compressed. And you can see how that deforms the spine into that sort of hunchback position. How do we treat compression fractures? Well, the best way is to let nature heal them. So we allow patients to rest for a while. I don't really use much physical therapy for this, but put it on the slide anyway. Bracing is used sometimes, but mostly we rest the patients and see if they'll get better by natural processes. However, the problem is if you have elderly patients and you put them to rest, they really lose their physical conditioning and they develop problems related to bed rest and immobilization. And so rest is not always a good treatment, but it does work for many compression fractures. If the patient's getting better over a couple of weeks, they may not need any further treatment. But one thing we can do is use the kyphoplasty to augment the vertebra with bone cement. And here's the studies showing some improvement and pain relief. How is it done? We put these balloons into the spongy bone of the vertebra under a general anesthetic. We guide those balloons in under x-ray guidance, and then we inflate the balloon to create a little cavity there. You can see how the balloon will create a cavity in that bone. We withdraw the balloon and then inject some bone cement. The benefits of a kyphoplasty are that it is a simple procedure. It's outpatient surgery. The patient gets 2 little stab wounds on their back. It sort of looks like they got bit by a rattlesnake right over the spine. It's a small incision surgery. It's safe. We apply the bone cement, which is quite safe to use. There's minimal blood loss, sometimes only a drop of blood, if any. Very little infection risk, if any. And the patients really, when they leave the outpatient suite from the procedure, are pretty much done with the treatment. It doesn't require a lot of physical therapy or rehabilitation. The risks of the procedure, it requires a general anesthetic, which always entails a minimal risk. Occasionally, the bone cement can leak outside the vertebra where you don't want it to go, but typically the skillful application of the procedure, that's not a problem. It's not suitable for all vertebra fractures. If you have a fragment of bone that's pushed back into the spinal canal, compromising the nerves, you don't want to inject stuff into the bone because that's going to push that fragment further into the spinal canal and compromise the nerves further. So it's specific kinds of fractures that can be treated with kyphoplasty. Here's the equipment. We use this trocar, which is the device with the blue handle up there. You saw one of those in Dr. Jane's presentation. And instead of putting a radiofrequency probe in, we put the balloon thing in, and you can see the syringe with the radio contrast agent that gets injected to inflate the balloon, and the little pressure monitor that records how much pressure the balloon is being inflated with. Here you see an example of that balloon in the surgical setting. It's injected with the radio contrast agent so we can see it while we're doing this all under X-ray. The whole procedure is done under X-ray, of course. And here you see an example of the procedure in process. General anesthesia, a sterile field. We guide those trocars where we want them and place the balloon. Here's the exact step-by-step procedure. We line up the patient under anesthetic and map out the vertebra that's involved with an X-ray unit. We draw the little lines on the skin to tell us where to place those balloons, and then prep the patient as sterile prep. We now check our alignment and get prepared to place those trocars into the bone. We place them in there, gently tapping them in position with a little hammer there, and it's all done under X-ray, so we know exactly where these trocars are going. Once the trocars are in a good position, just as you see here, now on the left screen, you can see the trocars from the front view of the spine, and on the right screen, you see the compressed vertebra and the trocars in position. Then follows a little drill, and then follows the placement of these balloons. And you can see the two balloons on that right screen are floated into the body of the vertebra. We inflate the vertebra with the pressurization gadgetry. Here's a picture of that patient that you saw earlier with the balloon being inflated. Sometimes that balloon will elevate that compressed vertebra end plate and actually restore the shape of the vertebra. That doesn't happen all the time, but when it does, that's very favorable. And so you see the balloons deploy, they create a cavity in the bone. And now we mix our bone cement. And this is a clever gadget that the Stryker people have evolved. And you'll see how the bone cement mixes up. They put this monomer into the powder of the polymethyl methacrylate. And you'll see the subsequent process here. You screw the top down, you hit the button, and this stuff mixes up very nicely. It smells like a surfboard shop in there while we're doing this. If you've ever been to a surfboard shop, you know what the bone cement smells like. And you'll see here that the cement is mixing very nicely on this automated process. And then, as you observe here in a minute, the cement gets deployed into this special syringe that injects it into the bone. So watch as the cement now deploys into the syringe. And then that syringe is attached to our deployment cannula, which you see over here on the back table. Once the cement is mixed and loaded, we kind of squirt some out on the surgical field because the cement is undergoing a chemical reaction. It sets up, and as it starts to set up, it gives off some heat. But when the cement is very liquidy, we don't want to inject it because it might squirt in places we don't want it to go. So we kind of let it set up a little bit. We deploy the cement in the cannula, and we're doing this under X-ray. I always like the cement to be a little bit like some firm toothpaste before I inject it. If it's too liquid, it can go places you don't want it. But if it starts to look like toothpaste, it's getting in the right state for me. You see here a picture of the cement deploying into the vertebra on the left, and then additional cement on the right side of the screen there. Here's the final product. You see the bone cement reinforcing that compressed vertebra in both the front and side projections. This is a good procedure for people that need it. It's very gratifying because sometimes people wake up in the recovery room and they feel better than they felt before they went into the procedure. and it has very minimal risk and is widely accepted and very satisfying to perform. Thank you very much, and I'm going to turn the discussion over to Mr. Ortgies, who will direct some questions from our audience to our panelists tonight. Thank you very much, and look forward to seeing you if you ever need us at the Southern California Orthopedic Institute.
Excellent presentations. Wow. Covered a lot of material there tonight, minimally invasive procedures to relieve pain and improve function. We got a lot of questions, and I'm going to read some of those off, and I'll call out the doctor I think would be most appropriate to answer. Let's start with the kyphoplasty with Dr. Shopler. That was very interesting. Question came in, can spine fractures cause you to hunch over? And if kyphoplasty repairs the fracture, will it also improve posture?
That's a good question. And often we see people that have had multiple osteoporotic compression fractures who really develop an unfortunately hunched forward posture. We've all seen sometimes in senior ladies the development of this round back posture that they get as a result of compressing their vertebrae. Often we can help that in terms of pain relief, but the kyphoplasty procedure seldom will correct that big deformity. We can't really fix that very often, unfortunately.
How about one more on the cement? There was a lot of questions about the cement, and I group them all together here. Are there any long-term consequences of the cement, allergic or such?
Bone cement has been used in orthopedic procedures for decades and decades. Goes back to the 1960s when we started to cement total hip prostheses into bone. And I've never really seen anybody develop an allergic reaction to the polymethyl methacrylate cement. So no, I don't think it has any biologically bad side effects to its application in bone. Sometimes in patients who have bad osteoporosis, when we do a kyphoplasty procedure, the bone with the cement in it is now harder and firmer than the bone next to it. So sometimes the bone next to it will subsequently fracture because it's being compressed against a now very hard surfaced bone. So once in a while, we see patients who need a sort of a kyphoplasty in one vertebra, and then the cascade is a year later or 2 years later, they come in and need a kyphoplasty at the next vertebra. So sometimes that does happen.
That makes sense. Let's go back to the Tlif. I got a question here for Dr. Grossman regarding the spacers. How long will the spacers last?
They last for the patient's lifetime. Once they're in, they don't come out. They're inserted with bone graft, and that bone graft then grows into the adjacent bones, and it stays there forever.
Is the minimally invasive surgery covered by insurance, specifically Medicare?
Yes, Medicare does cover the procedure. And most commercial insurances also do as well, although oftentimes the procedure will have to undergo a utilization review to make sure that the surgeon has chosen the right procedure for that particular patient.
Of course. Another question, Dr. Grossman, if you will. How long is a hospital stay with an Tlif type procedure?
On average, 1 or 2 nights. I've actually done some of these procedures as an outpatient procedure, but that's rare. I would say the majority of patients stay 1 or 2 nights. Now, of course, if you're doing multiple levels with screws and rods in the back, that patient might spend 3 or 4 or even longer.
Here's one for Dr. Falacasa on the Tlif and also back fusion surgeries. What is the success rate of spinal back fusion surgery? Is it 50% or less?
So it depends on the overall goals of the surgery and the pathology of the patient. I would say patients that have evidence of instability and compression of a nerve, complaining of both back and significant leg pain, the success rate in my practice has been well over 95%. So it kind of depends on what is going on, what the diagnosis is, what the symptoms are, and what the images studies are. But typically when we do decide to do a fusion procedure, particularly in instances like we discussed where there's significant compression of the nerve with back and leg pain, these procedures are highly successful.
Excellent. Here's another one for you, Dr. Falacasa. I'm 70 years old. Am I too young or too old for spinal surgery?
So I think in this day and age, 70 is the new 50 or 60. It kind of depends on your overall health. I've had many 70-year-olds that are very active, very healthy, not having too many significant medical issues like diabetes, osteoporosis. And I'd say if you're an overall healthy patient, depending on your overall medical clinical picture, I think 70 years old is definitely not too old for surgery. So I think it depends on the patient. So I've had patients in their 80s that have really benefited from surgery as well. So it kind of depends on your overall medical status.
Great to know that's not a limitation. Dr. Jain, regarding the Intercept procedure, how long after the Intercept procedure should we expect pain relief? Is it immediate?
Yeah, most patients do get pretty immediate pain relief after 1 to 2 weeks, and are returning to all function and activities after 1 to 2 weeks after the procedure with no postoperative restrictions on lifting or activities.
And how, regarding that recovery period, is physical therapy utilized in that, with that, or is it a more of a healing procedure and timeline after the surgery?
Typically, physical therapy is not required after the Intercept procedure, as most patients are able to return to their functional level before surgery immediately, and even note improvements after, which is normal recovery and doing activities of daily living.
If Intercept, Dr. Jain, if Intercept burns the nerves, what is the risk of nerve damage and paralysis?
The risk of nerve damage is quite low, less than 0.5%. And that nerve damage, when occurs, is almost always temporary and gets better within 8 weeks with a course of treatment, including anti-inflammatory steroids and epidural injections. The risk of paralysis is absolute zero, as all of these procedures are done below the spinal cord level. So there's no risk of paralysis of any kind. And again, any kind of nerve injury or weakness is extremely low, as we're targeting one specific nerve and not the large nerves that travel from the brain into the legs and control motor function of the lower extremities.
That's encouraging. Dr. Shopler, I've heard of friends who are having vertebroplasty. How is vertebroplasty different than kyphoplasty?
They're similar but different. The vertebroplasty is done with the cement, but no balloon. So sometimes they're undertaken by radiologists in a radiology suite and so forth. And they're just simply injecting the cement into the bone in an effort to make it harder and stronger. I personally prefer the kyphoplasty because I think it allows a more precise and accurate deployment of the bone cement. I think that in training in orthopedics, we get a lot of experience with use of bone cement, so we're used to dealing with it. And I don't think a lot of specialists outside of orthopedics have that same kind of experience. So I feel much more confident doing a kyphoplasty than a vertebroplasty.
Super. Another one for you, Dr. Shopler. Can kyphoplasty be done on old fractures?
That's a good question. There was a paper a couple of years ago that showed that kyphoplasty is effective at fractures up to 2 years of age. And that is consistent with my findings in my practice. I've seen patients who've had very old collapsed fractures of their vertebrae who say that they've been in pain for a couple of years and it just never healed. It never got better. It never got better. And we did a kyphoplasty, and sure enough, they got substantial relief from the procedure. It's never a miracle because the patient still has osteoporosis typically, and so they may have some back pain and some degenerative discs, just like you've seen elsewhere. But in terms of the fracture pain, it's very effective even in late treatment.
This one for Dr. Grossman, relative to that, are procedures done on multiple, like T4, T5 levels, or is it one at a time when the spacers are put in?
We often do multiple levels, and in general, they're all done at the same time under the same anesthetic. I showed one case that the patient had 5 Tlif implants inserted, and those were all done under the same anesthesia.
So not 5 surgeries, it was 5 procedures within that episode.
Exactly.
Super. This one just came in for Dr. Jane. How painful is the nerve ablation?
The nerve ablation is very minimally painful. It's tiny percutaneous incisions, less than 1 centimeter the size of kyphoplasty incisions in the back. So very, very minimal pain. Typically, patients only require Tylenol, over-the-counter anti-inflammatories, and some ice to help control their pain after the procedure.
This is a tough one. What happens if the Intercept procedure doesn't work? How long do I have to wait before proceeding with another option? Have you encountered something like that?
Very rarely have I encountered that, but one of the beauties of the Intercept procedure is it doesn't change any structure in the spine that makes any future surgeries any harder. So if I did an Intercept procedure on a patient and 3 weeks later they said they were no better and still having pain, you could immediately proceed with any of the other procedures, including X-Lif, Mass T-Lif, Open T-Lif, A-Lif, any other fusion procedure, and it wouldn't delay your procedure or make it any harder.
Excellent. This one came in for Dr. Falacasa. I think we did that. Will I become stiff after the result of the surgery? And do I need to wear a brace?
It's a great question. So it kind of depends on how many levels we'd be fusing, but typically with 1 and 2 level fusions, especially when we're doing these fusions, there's already a lot of stiffness because of the disc being significantly degenerated. So most of my patients don't really realize any significant stiffness, especially if they only have, a 1 or 2 level fusion. As far as a brace, I do give patients a brace to wear. I have them wear it initially after the post-operative period, just, when they're out of bed and ambulating long distances. And I have them really wear it for the first 2 weeks, and I kind of have them kind of gradually just wear it as needed for the first 3 months if they're, in the car driving or, walking long distances. And the idea of the brace is more for just the patient to feel like a little bit more secure, safe, and just to kind of remember that they had recent spine surgery, even though they might be feeling amazing and great, to kind of just, have them be a little bit more cautious.
And Dr. Grossman, that same question came in for you for the X-Lif. Do you want to expand on that about a brace?
Yeah, I feel the same way as Dr. Falacasa. I provide a brace to the patient, and it's more to remind them that they had recent surgery so that they don't go out and overdo it. And I'll usually have them wear a brace for 6 weeks or so post-op. The brace itself doesn't really provide a lot of stability, but it does prevent the patient from making moves that might put the early fusion under stress.
Okay. Dr. Shopler, I just lost it here. I have a lot of allergies. Is there any concern for me to have the cement in my body? Is it possible to have an allergic reaction to the bone cement?
It's never been my experience that a patient has a bone cement allergy. The bone cement is radio opaque, as you see on the x-rays. It blocks x-rays, is why you can see the cement on the x-ray. And the thing that makes it opaque is barium. And if you know anything about studying the gastrointestinal tract, people frequently have to swallow barium to get GI studies done. Anybody who's allergic to barium probably ought not to have a kyphoplasty, but I don't think I've ever met anybody or seen a patient who's allergic to barium. The radio contrast in the balloon is, some people have an allergy to radio opaque contrast agents, and there'd be a little risk from that because the contrast is contained in the balloon. I suppose if the balloon were to rupture, that contrast would ooze into the patient's circulation. But these are really hypothetically rare things. I've never essentially seen it happen. So essentially non-existent risk.
Super. Dr. Grossman, will my height change with the spacers that are put in? 1, 2, 3, 4, or 5?
Yes, the height will increase, but I think I wouldn't recommend doing the procedure just to increase your height. Yes, when you elevate a disc, it does increase the patient's height slightly. Probably not really noticeable.
This is kind of to anybody who wants to answer this. Besides having pain, what happens if I do nothing to treat osteoporosis spinal fracture? Maybe Steve, why don't you try that?
I'll take that. I'll take that. The patients who have osteoporotic spinal fractures usually have pretty bad osteoporosis. And osteoporosis is of itself a painful problem to have. So people with osteoporosis typically will have a sore back, even if they have not fractured a vertebra. It just hurts to have osteoporosis, especially in the spine. And so most people with osteoporosis will develop some back pain. And of course, osteoporosis also puts you at risk for other fractures that we refer to in orthopedics as fragility fractures, because the patient's bones are fragile. When an older person falls down, they're at risk for a hip fracture, and that's a fragility fracture. People also fall down and break their wrists because the bone's soft, and that's typically a fragility fracture in the elderly. You don't see those kind of fractures in teenagers or young adults because they have strong bones. Yeah, sure, they break their bones, but it's a different kind of fracture. The fragility fractures are a big risk for people with osteoporosis.
That's a good word. I hadn't heard that word. That's a fragility fracture. That's a great one. Dr. Jane, how long does pain relief last after an Intercept procedure? And is a second surgery ever necessary?
So the Intercept procedure is so new that the very first ones were done 5 years ago for the initial studies to get the FDA approval. And the data from those studies show that it's still effective out to 5 years. Now, we don't know if it's going to last 5 years and 1 day, or 50 years or 500 years. We just don't know yet because they haven't been done long enough for us to know that. I tell people you can expect at least 5 years of relief if it's going to work, and that's great. It can always be repeated if the nerve does regrow, but to date, we haven't really seen that. And you can always proceed with the other procedures of fusion as needed if it doesn't work. And the nice thing is it doesn't make your fusion any more challenging, any harder, or require any extra work to do that if that is something you eventually need. But the vast majority of patients who have this problem and are treated with the Intercept do not require further surgeries.
And as I asked Dr. Grossman earlier, is the Intercept procedure covered by insurance, including Medicare?
It is covered by insurance, not in every situation, and it does take a little bit of work because it's so new. It's often considered experimental, but with a little bit of patience and a little bit of work, we have a very good system dialed in with the special portal to help get insurance approvals. And certainly Medicare is the easiest and fastest to get approval and authorization to proceed with this procedure with.
Dr. Jane, I'm going to stay with you one more second. I hope I read this correctly.
Of course.
How much range of motion is compromised, particularly in the lumbar vertebrae? Actually, I apologize. That's for Dr. Grossman. That came in Dr. Grossman, how much range of motion is compromised by spinal fusion, and particularly with lumbar vertebrae are fused?
So regardless of whatever technique is used to fuse the spine, the loss of motion is proportional to how many levels are fused. With a 1 or 2 level fusion, there's really not that much of a noticeable loss of motion. Patients can still bend forward, tie their shoes, pick things up off the floor with a 1 or 2 level fusion, because most of that motion actually takes place in the hip joints and not in the lumbar spine itself. When you get up to 3, 4, 5 level fusions, then it becomes noticeable, especially with twisting motions. But most patients, even with multiple level fusions, tolerate that quite well.
Sounds like good pain relief. Dr. Jane, here's the question I wanted to ask you. Do the probes sense nerves on the inside of the disc or on the outside? And how much pain reduction in general does it give?
It depends on which procedure you're talking about. For the Intercept procedure, the probe targets a nerve, one nerve, the basovertebral nerve, specifically within the bone. So it's inside the bone, and it goes from the bone to the end plate of the bone, which touches the disc, and it transmits the pain signals from the disc into the nerve in the bone and then into the spinal column and up to the brain. So when we cut off the basovertebral nerve that's within the bone, we cut off the signal of the pain from the disc to the brain. There's lots of other nerves in the spine. You have the major nerves that travel through the central canal and exit out at each level. And those are the spinal nerves that turn into the sciatic nerve and control motor and sensory function in the lower extremities. And we're not messing with those. We're going nowhere near those nerves. And then you also have the small medial branch nerves, which are sensory nerves that go posteriorly to the facet joints in the back. And those control the facet-related pain and transmit the pain signals to the brain from the facet. So different ablation procedures that were more commonly done for a lot longer have targeted those medial branch nerves, which just sit outside the bone on the facets and are very easy to access. And any pain management physician can do that. It doesn't require a spine surgeon to access those. Whereas the basovertebral nerve is within the vertebral body and takes a little bit more skill and training to successfully and safely access.
Fascinating. I'm going to jump back to Dr. Grossman again. What is the recovery time after an XLIF? I think we talked about the hospital stay, but did we ask the recovery time typical?
Well, so recovery involves the bone healing and fusing. You know, if you fall and break your wrist and the doctor puts you in a cast, it takes as long as 3 months for that bone to fully heal and remodel. And with fusion, we're mimicking a very similar process. So it's about 3 months minimum for a solid fusion to occur.
That's the gist of the questions that I got in here through the portal. We've got about another 5 minutes, and I'd just like to kick it back to our expert panelists. And I'd like to just go around the horn from Dr. Grossman to Dr. Falacasa to Dr. Jane. We'll finish up with Dr. Shopler. Last statements, and then we'll close out the program. Dr. Grossman.
Well, I just want to acknowledge my partners. I enjoyed this evening getting to meet with you guys and discuss some spine surgery. And it's, it's an honor to be part of a group that we have here at Southern California Orthopedic Institute. We have 6 spine surgeons, and it's like being part of a university center with a subspecialty group. And I really enjoy participating. So thank you all.
Thank you.
Yeah, I agree. It's an amazing practice. It's great because, we have people with so many different styles, and all of us kind of perform a lot of these procedures we talked today. Like I performed the XLIF procedure, the Tlif procedure, so does Dr. Jane. And I think it's also great not only to be a part of such a great team, but it also ensures that all the patients are getting the best care possible. Just because we often have conferences together, and if we often see a case that's difficult, it's nice to be a part of a big group with 6 board certified spine surgeons from amazing backgrounds and amazing experiences to make sure that all our patients are always getting the best quality of care. And also, we all make sure that we're always doing the best thing for all of our patients. And we all work as a team. So if you see me or Dr. Grossman or Dr. Jane or Dr. Shopler, it's nice that, in a way, you're kind of seeing all of us, because if there's anything that, we think needs a second opinion or needs further workup, we often, share these cases with each other. We have spine conferences, and we just work as a team and as a unit to make sure that everyone gets the best care possible. So thank you so much for listening to our lecture tonight.
Yeah, I couldn't agree more or echo what Dr. Grossman and Dr. Falacasa were saying. We have a wonderful organization here, and we love taking care of patients and trying to make people better. Of all of these procedures we talked about today, the one thing I would like to reiterate is that every patient is different and every patient is unique. And, there's not a one-stop answer or one solution for every problem. And that's what makes spine surgery so exciting. And what gets us excited as spine surgeons is trying to tailor and figure out the right procedure for every individual and their lifestyle, their individual imaging, their individual problems. And spine surgery is not one solution for every problem.
I would just like to close by saying that every procedure that you heard discussed tonight did not exist when I was trained.
Steve, you just muted yourself.
I'm sorry, I was currently muting myself. Let's try that again. What I wanted to say is, in closing, that every procedure that was discussed tonight by our panelists, every single one of those procedures did not exist when I was in training in orthopedics in the 1980s and early 90s. What we're doing now is, in those days, every spine procedure was a big, huge cut down the middle of your back and about 2 units of blood loss and a big, painful process and sometimes a body cast. And people had a lot to go through to recover from those kind of surgeries. And while I don't think we've achieved perfection in spine surgery, we certainly made huge inroads compared to what I used to experience doing these procedures years and years ago. And I think tonight's topics are testimony to the fact that we do some pretty up-to-date things here at SCOE. And here in Bakersfield, we now have robotic assisted surgery, which I think will catch on everywhere. And I think that the spine world is very exciting and a good place to be right now. Glad to have my partners working on it with me.